Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 162 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, TJR, is a 31-year-old male patient with newly diagnosed HIV infection. His CD4+ cell count is 265 cells per millimeter cubed with a viral load of 42,456 copies per milliliter. TJR is due to begin HAART during today's clinic visit. His only concern is oral thrush, which he noticed while brushing his teeth this morning. So my question to you is, which of the interventions listed below would be the most appropriate for TJR now? Would it be A. Initiate fluconazole therapy orally for 7 to 10 days, or B. Suggest peroxide, have the patient rinse twice daily, and prescribe co-tremoxazole DS1 tablet orally 3 times weekly, or C. Prescribe azithromycin 1200 mg orally once weekly, or would it be D. Initiate 7 to 10 days of atovaquone therapy plus co-tremoxazole DS1 tablet orally once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Initiate fluconazole therapy orally for 7 to 10 days. Non-recurrent episodes of thrush may be managed with short-term courses of appropriate antifungal therapy, e.g., fluconazole. That makes answer A correct, and answers D and B incorrect. For this patient, whose CD4+ cell count is 265 cells per millimeter cubed, no opportunistic infection prophylaxis is indicated at this time. That makes answer C incorrect. Single and non-recurrent episodes of thrush are not considered AIDS-defining illnesses. Please advance to the next question. And the next question reads, MSC, a 55-year-old male patient with AML who underwent a matched unrelated donor HCT 120 days ago, now comes to the clinic for a follow-up. He was recently discharged from the hospital after receiving high-dose steroids for the treatment of graft versus host disease, abbreviated as GVHD. While MSC was in the hospital, voriconazole 200 mg orally twice daily was initiated for fungal prophylaxis. His current medications include prednisone 20 mg orally once daily, acyclovir 400 mg orally twice daily, mycophenolate mofetil 500 mg orally twice daily, lansoprazole, metoprolol, Docusay, and a multivitamin. The decision is made to continue the prednisone taper to 15 mg orally once daily but to add tacrolimus. So my question to you is, which of the following would be the most appropriate consideration regarding tacrolimus for MSC? Would it be A. Tacrolimus induces voriconazole metabolism, so the voriconazole dose should be empirically increased, or b. Tacrolimus inhibits voriconazole metabolism, so the voriconazole dose should be empirically reduced, or c. Voriconazole induces tacrolimus metabolism, so the tacrolimus dose should be empirically increased, or would be d. Voriconazole inhibits tacrolimus metabolism, so the tacrolimus dose should be empirically reduced. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Voriconazole inhibits tacrolimus metabolism, so the tacrolimus dose should be empirically reduced. Voriconazole is a potent CYP3A4 inhibitor, thus, the tacrolimus dose should be empirically reduced. That makes answer D correct and answer C incorrect. For patients receiving tacrolimus at goal concentrations, the tacrolimus dose should be reduced by 66% when concomitant voriconazole is initiated. Tacrolimus neither inhibits nor induces the metabolism of voriconazole. That makes answers B and A incorrect. Please advance to the next slide. And the next question reads, MSC presents to the clinic 90 days later. In the interim, he was hospitalized for the treatment of a presumed fungal pneumonia, during which MSC received 10 days of therapy with amphotericin B lipid complex and posaconazole 200 mg suspension 4 times daily. He was recently discharged to home with instructions to continue the posaconazole dose. A posaconazole trough concentration was measured before discharge, but, because it was a send-out laboratory test, the results are just now available. The trough concentration was sub-therapeutic. MSC tells you that he takes all 4 posaconazole doses daily but not always with food or a snack. So my question to you reads, which of the interventions listed below is most likely to increase MSC's posaconazole trough concentration? Is it A. Continue posaconazole, but change to tablet and give 300 mg orally twice daily for 1 day and then 300 mg orally once daily, or B. Continue posaconazole oral suspension, but change posaconazole dose to 800 mg orally once daily, and minimize acid suppressive therapy, or C. Continue posaconazole oral suspension, but change posaconazole dose to 400 mg orally twice daily, and minimize acid suppressive therapy, or is it D. Continue current dose of posaconazole oral suspension, and minimize acid suppressive therapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Continue posaconazole, but change to tablet and give 300 mg orally twice daily for 1 day and then 300 mg orally once daily. Posaconazole suspension is best absorbed with food, ideally food higher in fat. Moreover, in the fasted state, acidic carbonation improves posaconazole absorption of posaconazole suspension. Posaconazole suspension requires an acidic environment for absorption, and avoidance of acid suppressive therapy is recommended, if possible. In addition, posaconazole oral suspension has saturable absorption, so changing the dose from 200 mg orally 4 times daily to 400 mg twice daily or 800 mg once daily would not improve drug exposure. That makes answers B and C incorrect. Recently, a delayed-release tablet formulation of posaconazole was approved with more reliable absorption than the oral suspension. In addition, the delayed-release formulation may be given with concomitant acid-suppressive therapy. Like the oral suspension, the oral tablet should be given with food, though its absorption is less dependent on gastric state. Because this patient is not taking all of his doses of posaconazole suspension with food, it is reasonable to change to the tablet formulation for improved absorption and less dependence on the fed gastric state. That makes answer A correct and answer D incorrect. Please proceed to the next question. And the next question reads, AJF, is a 47-year-old male renal transplant recipient who takes itraconazole 200 mg capsules orally twice daily for histoplasmosis. He takes the capsules twice daily, first thing in the morning 1 hour before breakfast and in the evening 1 to 2 hours after dinner. He presents in the clinic for a follow-up, and his itraconazole trough concentration is subtherapeutic. So my question to you is, which of the options listed below would be the most appropriate recommendation in AJF's scenario? Would it be A. Keep the current itraconazole dose, but change the formulation to an oral solution, and encourage the patient to continue his current administration schedule, or B. Keep the current itraconazole dose, but change the formulation to an oral solution, and encourage the patient to take the medication with food, or C. Increase the itraconazole dose of 200 mg capsules from orally twice daily to orally thrice daily, and encourage the patient to take the medication with food, or D. Continue with itraconazole 200 mg capsules orally twice daily, and encourage the patient to take the medication with food. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Keep the current itraconazole dose, but change the formulation to an oral solution, and encourage the patient to continue his current administration schedule. Itraconazole capsules are up to 55% bioavailable with food, whereas the oral solution is up to 100% absorbed in the fasting state. Because the patient has a demonstrated pattern of taking the medication on an empty stomach, it is most appropriate to change from the capsule to the oral solution, especially because the solution has more reliable absorption than the capsule. That makes answer A correct and answers D and B incorrect. If a patient refuses to take the oral solution because of GI intolerance, it is recommended to optimize the administration of the capsule with food at the current dose before increasing the dose. That makes answer C incorrect. And the next question reads, DCB, a 55-year-old male patient was diagnosed with AIDS in 2004. The patient's viral load then was 175,000 copies per milliliter, and his CD4+ cell count was 12 cells per millimeter cubed. Throughout DCB's illness, he has received diagnoses of, and been treated for, PJP, VZV, and several episodes of community-acquired pneumonia. For the past 24 months, his viral load has been less than 48 copies per milliliter, and his CD4+ cell count has been no lower than 350 cells per millimeter cubed. So my question to you is, which statement below regarding DCB is most consistent with current guidelines? Is it A. He may initiate therapy with antibiotic prophylaxis for the prevention of recurrent community-acquired pneumonia, or B. He is a candidate for the VZV vaccine, or C. He is likely receiving therapy with both azithromycin and cotrimoxazole DS, or is it D. He is probably not taking any OI prophylaxis currently? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. He is probably not taking any OI prophylaxis currently. Despite this patient's history of PJP infection, prophylaxis is no longer required because the patient's CD4+ cell count has been above the threshold for prophylaxis, greater than 200 cells per millimeter cubed, with an undetectable viral load for several years. Secondary prophylaxis is indicated only if the patient's cell count is no greater than 200 cells per millimeter cubed for at least 3 to 6 months in conjunction with an undetectable viral load. That makes answer D correct and answer C incorrect. Varicella vaccine may be considered in VZV non-immune patients with a CD4+ cell count greater than 200 cells per millimeter cubed, but it is not indicated in this patient because of his previous VZV infection. That makes answer B incorrect. Prophylaxis against community-acquired pneumonia with antibiotic therapy is not advised, which makes answer A incorrect. Please advance to the next question. And the next question reads, OJT, a 35-year-old female patient presents to an outside hospital with a chief complaint of new-onset fever, night sweats, and weight loss. She has a past medical history significant for an allogeneic HCT for aplastic anemia that was complicated by graft versus host disease, abbreviated as GVHD. She is currently stable on tacrolimus 3 mg orally twice daily, and mycophenolate mofetil 500 mg orally twice daily. OJT has a history of a positive IgRA test, which was treated appropriately with isoniazid and rifapentine before HCT. The infectious diseases consultant was consulted at the outside institution, and the patient is initiated on rifampin, isoniazid, pyrazinamide, and ethambutol. 10 days later, OJT is transferred to your hospital. Original presenting symptoms have largely resolved, but she now has abdominal pain, diarrhea, and a new rash on her arms and abdomen. So my question to you is, after reviewing the case, which of the following would best be prioritized as the most likely problem with OJT? Would it be A. TB reactivation because of failure of LTBI treatment, or B. Graft versus host disease, GVHD because of decreased immunosuppression from drug interaction with rifampin, or C. CMV colitis because of increased immunosuppression from drug interaction with rifampin, or would it be D. Hepatotoxicity from TB medications? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Graft versus host disease, GVHD because of decreased immunosuppression from drug interaction with rifampin. The most likely culprit in this scenario is decreased immunosuppression caused by the drug interaction with rifampin and tacrolimus, which may lead to the development of graft versus host disease, GVHD, which makes answer B correct. Rifampin is a potent CYP3A4 inducer that requires substantial dose increases in tacrolimus to maintain therapeutic concentrations. Thus, it is unlikely that CMV colitis developed because of increased immunosuppression in this scenario. That makes answer C incorrect. Hepatotoxicity from TB medications should always be considered, but it would probably not cause rash unless a drug allergy were a possibility as well. That makes answer D incorrect. Moreover, active TB rarely develops when LTBI is treated appropriately, which makes answer A incorrect as well. Please advance to the next question. And the next question reads, KBT, a 36-year-old male patient presents to your infectious diseases clinic because he is on the renal transplant waiting list and his IGRA test was strongly positive. The infectious diseases attending decides to treat LTBI, so my question to you is, which of the following would be the best agent at this time? Would it be A. Defer treatment of LTBI until after transplantation, or B. Give rifampin 600 mg orally once daily for 6 months, or C. Give isoniazid 300 mg orally once daily for 9 months, or would it be D. Give isoniazid 300 mg orally once daily for 6 months? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Give isoniazid 300 mg orally once daily for 9 months. The first-line treatment for LTBI is isoniazid 300 mg orally once daily for 9 months, which is more efficacious than the same regimen for 6 months. That makes answer C correct and answer D incorrect. Of importance, this regimen needs to be given with pyridoxine to prevent neuropathy. Rifampin 600 mg orally once daily is an alternative but is given for 4 months, not 6 months. That makes answer B incorrect. Of note, this medication has substantial drug interactions with immunosuppressive regimens and is only given to patients not expected to undergo transplantation before LTBI treatment is complete. Treating LTBI post-transplantation is a possibility, but generally, it is better to treat LTBI before bolus immunosuppression. That makes answer A incorrect. Please proceed to the next question. And the next question reads, MPM, a 34-year-old male patient presents to the pulmonary transplant clinic. He has a chief complaint of new-onset fever, headache, and worsening shortness of breath for which he is admitted to the hospital. MPM undergoes bronchoalveolar lavage. After the procedure, his oxygen requirements increase, and he is transferred to the medical intensive care unit for closer monitoring. He has a past medical history significant for cystic fibrosis and he underwent his second bilateral lung transplant 8 weeks ago. He has no known drug or food allergies. He received antithymocyte globulin and methylprednisolone as induction immunosuppression and subsequently received high-dose methylprednisolone 21 days ago for empiric treatment of rejection. Gram stain from the respiratory cultures reveals beaded gram-positive rods of concern for Nocardia species. So my question to you is, which of the following would be the best initial treatment for MPM? Would it be A. Imipenem cilastatin 500 mg IV 4 times daily and linezolid 600 mg orally or IV twice daily, or B. Cotrimoxazole 15 mg per kilogram per day, depending on trimethoprim component, orally or IV divided into 3 or 4 doses, and imipenem cilastatin 500 mg IV 4 times daily, or C. Imipenem cilastatin 500 mg IV 4 times daily, and amikacin 5 mg per kilogram IV once daily, or would it be D. Cotrimoxazole 15 mg per kilogram per day, depending on trimethoprim component, orally or IV divided into 3 or 4 doses? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Cotrimoxazole 15 mg per kilogram per day, depending on trimethoprim component, orally or IV, divided into 3 or 4 doses, and imipenem cilastatin 500 mg IV 4 times daily. Cotrimoxazole is the drug of choice for primary therapy of stable pulmonary infection caused by Nocardia species. However, given this patient's worsening respiratory status and concern for CNS or disseminated infection, headaches, combination therapy is most appropriate. That makes answer D incorrect. The combination of imipenem and cotrimoxazole or imipenem cilastatin and amikacin is considered first-line therapy. Amikacin should be dosed at 10 to 15 mg per kilogram intravenously once daily. That makes answer C incorrect, and answer B correct. Linezolid is an alternative agent that may be considered if one of the first-line agents cannot be used, which makes answer A incorrect. Please proceed to the next question. And the next question reads, DMP, is a 45-year-old HIV seropositive female patient who entered care after an episode of acute PJP that required intubation and IV therapy. During her PJP illness, a history of a sulfur allergy was discovered. Her current meds include ARV therapy for HIV, dapsone, omeprazole, zolpidem as needed, fluconazole, and ondansetron PRN. Currently, the patient's viral load is 1,000 copies per milliliter, down from 292,000 copies per milliliter 3 months earlier, and her CD4+ cell count is 88 cells per millimeter cubed. So my question to you is, in reviewing her medication therapy, which of the interventions listed below would be is most appropriate in this clinical scenario? Would it be A. The current regimen provides insufficient prophylaxis against toxoplasmosis, or B. If continued therapy is anticipated, administer dapsone intravenously, or C. Add azithromycin 1,200 mg by mouth once weekly, or would it be D. The patient requires no alterations or additions to pharmacotherapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. The current regimen provides insufficient prophylaxis against toxoplasmosis. This patient's CD4+ cell count is 88 cells per millimeter cubed, placing her at risk of reinfection with PJP and new infection with toxoplasmosis. Because her cell count is less than 100 cells per millimeter cubed, dapsone is being prescribed as prophylaxis in place of trimethoprim, sulfamethoxazole, presumably to avoid a sulfur reaction. Although dapsone itself may induce sulfur reactions, this is less common than with cotrimoxazole. Although trimethoprim, sulfamethoxazole will provide prophylaxis against toxoplasmosis, dapsone will not. Therefore, additional therapy is required to adequately prevent this infection while the CD4+ cell count remains less than 100 cells per millimeter cubed. Answer A is correct, and answers B to D incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 163.